Hello and welcome to NewsClick. Today we're going to discuss the evolving COVID-19 situation in India, and we have with us Dr. Satyajit Rath of the Indian Institute of Science, Education and Research. Thank you so much, Dr. Rath, for joining us. So, first of all, I just wanted to start with a question about the government's claim yesterday that there is still no community transmission in India. Now, there's been a lot of debate over these terms, whether they're actually, accurate or whether they're actually even relevant considering the situation. So, what is your take on it?
So there are 3 points that I think we need to keep in mind. The first point is that at some level, this is a semantic debate.
Right.
What is a local transmission situation and what is a community transmission situation is essentially a matter of numbers.
Right.
When local transmissions, in other words, become large enough in numbers, both in terms of multiple local transmission, that number, and the size of each local transmission, that number, when those numbers achieve a certain level, a certain size, you begin to say, oh, there's community transmission.
Right.
So at some level, this is a semantic point. The second issue is that the distinction between a local transmission and a community transmission, in terms of what our policy response should be, is again relatively fine parsing. We are going to do containment, we are going to do detection, we are going to do aggressive identification, and we are going to try and persuade the community into physical distancing, rather than beat the community into physical distancing. But those are things that we would do even if what we had was local transmission alone. So it's simply going to add to the urgency of our efforts if we have community transmission. For epidemiologists, there are different likely consequences if an epidemic stops at the level of local transmission versus if it achieves true stable community transmission in terms of just how large the epidemic will end up being. But that's not really going to impact major differences in policy. The third point, which is somewhat evil of me, is that ICMR itself seems to have said in the recent past that there is community transmission. So I wish that ICMR would deal with its internal schizophrenias and talk to us as a stable personality.
Right. So one thing that is definitely that all of us, everyone seems to agree is the need for more testing though. And as of today, I think the number of tests is still at around 1.5 lakh, which is one of the lowest in the world. So in this context, there's been a lot of talk about the more rapid testing kits that are slowly being deployed. So could you tell us a bit about how useful and effective they are, and as a policy measure, how should the deployment be?
So I keep coming up with this 2 issues, 3 issues kind of response. But there are 2 categories of factors in response to this question that I think are important to keep in mind. The first factor is, which test are we talking about? So remember that infection is detected by detecting the virus,
right,
the nucleic acid sequence of the virus. So currently what everybody is doing is using, by and large, as far as I know, a reverse transcriptase polymerase chain reaction kit, an RT-PCR kit. This is expensive, it needs instrumentation. There is potentially a rapid version of, or not exactly rapid, but perhaps a somewhat cheaper version of this kit called a LAMP kit that still detects nucleic acids. I don't know if there are any LAMP methodology-based kits out there at all. Currently, as far as I know, I may be mistaken on this, but as far as I know, everything is RT-PCR driven. That's what is detecting active infection. That takes its own time. Times are not enormous. They are a few hours. Most of the times, What takes time is the fact that the test is not point of care. In other words, you can't take a sample from me and do the test there. You have to transport samples, which means you have to accumulate a few samples, then some courier on contract with no health insurance and protection is going to take those samples somewhere, dealing with all the police blocks on the way. At that laboratory, they are going to put the kit together, and because kits work most economically when a large number of samples are done together, they're going to wait, and this is what is taking time. So it's not that the test takes time.
Right.
The logistics of a technologically specialized test take time. So that's what is going to be the difference between a slow test and a rapid test. Not so much the time that the test takes, but how much point of care, how close to the point of care the test can be realistically administered. At this point, as I said, the lamp-based kit might perhaps have come closer to the point of care. I don't think even that can be deployed at the point of care, but might have come closer. I haven't heard of lamp assays. And therefore, the cutting down of the duration is going to depend on refinement of logistics. So what everybody seems to be talking about as a rapid test, and again, people are confusing between different kinds of tests, so I'm always a little uncertain of which test who's talking about. Right. But what people seem to be talking about is, as the rapid test, is not a test that detects the actual presence of the virus. It's a test that detects the body's immune response to the virus, an antibody response to the virus. There are two issues with this rapid test. Number one, it's not detecting the virus. So it's not detecting infection. So all it is saying is, this person who tests positive for antibody has been exposed, has been infected with the virus at some point, either in the recent or in the far past. This is very different from saying this person is currently infected.
Right.
Both in terms of the individual involved and in terms of policy, these two outcomes are completely different in meaning. Secondly, even this test, in order to be measurable quantitatively, needs equipment that is not available at point of care. So what is available at point of care is a so-called strip test that can be done on a blood draw. As you would imagine, because it is a technologically approximated test, it has its own limitations. It's not a particularly quantitative test. So you have a yes-no kind of test, right, which is very limited information. And it has its own difficulties with false positives and false negatives. So this is what we are talking about in terms of tests. If we want to identify infected people, we need to be able to take technically well poked in swabs and to do virus detection.
Right.
On the other hand, we need to know what proportion of the community may have already in the past been infected by the virus and may never have had symptoms or had mild symptoms and recovered. This is important from a policy point of view. It's also important from an individual point of view because you would individually worry less if it turns out that you've already been recently infected and recovered. So deployment of these two tests needs to be thought about, number one, at the level of identifying patients. And in order to identify patients, of course, you would deploy virus detection tests at so-called hotspots, meaning wherever you've detected cases in and around that socio-geographical area. meaning in and around the contacts of that individual or those individuals and in the general geographical area, is where you would deploy the virus detection test. The antibody detection test you would want to deploy in a far more epidemiologically, statistically structured fashion to begin to ask where and in what proportions we have past evidence of past infection.
Right.
And it seems to me that while the first may be done to a significant extent now, the second is really not, as far as I can hear from public discourse, not being done to any plan and statistical epidemiological sampling model at all.
Right. Right. And on a connected basis, is there a specific reason / logic for the low number of tests, or is it just inefficiency that we are seeing here? Because are we having a logistical issue also right now?
Oh, we certainly have logistical issues. We are, I don't know the numbers that government has access to, but I can very easily imagine that our available test numbers are extremely limited because the world over they are going to be limited. Right. It's only countries which in January began placing orders for really large numbers of tests who will have at least some stockpiling of the virus detection tests. I'm not sure that the antibody detection tests have exactly the same problem. But as I said, they are not going to detect infected people unequivocally. So there is that as a logistic problem. The second logistic problem, as I pointed out, is that samples need to be taken from point A to point B and have to be handled together. And as anybody who has accessed public healthcare systems in India knows, none of this, with the best will in the world, necessarily works particularly efficiently or well in reality. The third issue in this limited number is perhaps a sort of wishful thinking where, we still have only about, what is it currently, 7,500 cases distributed across the country, and therefore we don't have, let me parse ICMR's language in their minds at least, we don't have robust community transmission like they had in Italy or like they have in New York. And therefore, we really don't need to test for virus that much, do we? And this is to a certain extent problematic, not because it's wrong, but because we don't know if it's right or wrong in the absence of testing.
Right. And on a connected note, there's also been a lot of discussion on the question of why we don't have that amount of spread. So, of course, at one level, it's all about, there's this whole mystic level of interpretation. But on a more serious note, there's also a lot of writing being done, and you have written about some of that writing itself, some papers talking about the various factors, whether it's the heat, whether it's some sort of natural immunity, whether it's previous vaccination that has actually contributed to maybe not that many cases. So as of now, with the latest information we have, is it even possible to make any conclusion, or are we just speculating in the air?
All right. So at this point, let me point to where all of this speculation, particularly with respect to India, originates ostensibly. It ostensibly originates in the claimed fact that we don't seem to have as much COVID-19. So I urge everybody to look at the trajectory of reported cases. Never mind the problem of are we identifying all cases or not.
Right.
Simply look at the trajectory of reported cases and look at the trajectory of reported cases in other countries where the trajectory has taken off earlier. The two lines are simply, by and large, delayed in time.
Right.
But they are running in parallel, more or less. So I'm not sure that the basis for this entire speculative edifice is sound. The second point that worries me about what I'm calling the soundness of this core claim is, if the argument is to be that in India, SARS-CoV-2 we are somewhat immune to, so we won't get terribly sick and so on and so forth. If that were the case, then our mortality rate should not be particularly high. Now, remember that case fatality rates are a very difficult calculation because they are number dead, which we by and large know at least a quasi-reliable number, over number infected, which, given the paucity and scrambledness of testing, nobody anywhere in the world is sure of, except perhaps the South Koreans and to some extent the Germans. So that number is always going to be noisy. But noisy as it is, at about currently what, 3%? 2.7%, 2.8%. It started with 2.5%, and it's slowly creeping up. That number is the global average. So again, where is this core finding that SARS-CoV-2 infection and COVID-19 severity of illness in India does not seem to be particularly serious?
Right.
I'm not seeing this. So if we are not seeing something that needs to be explained, why exactly are we going through all the explanations? Is something that tends to bother me greatly.
Right.
That said, if you want to discuss that, what I keep calling shaky pyramid of speculations, I'm more than happy to do so. But we should keep in mind the core fact that the keystone of that entire edifice is not simply exceedingly shaky, it may not even be there.
Right. So yeah, but in connection to that, some of the papers that you have talked about earlier, just to sort of push that argument a bit further. So the argument about the weather, the immunity, the previous vaccinations and all that. So I just wanted to get your comments on those two.
So as I said, because I'm not sure that the empirical basis that needs these explanations exists, I'm going to focus on making somewhat more broader points in responding to this. So let me start with specific examples. There is a claim that weather patterns, geoclimatic distinctions between countries are showing an interesting distinction. And it is true that different viruses are more or less susceptible to having their transmission efficiency modified by weather, by seasons. Many infections are seasonal. So is it possible? Yes. Do we have evidence for it? No. Is this geoclimatic pattern that emerges in a preprint from MIT, and oh my, therefore it must be correct, is this reliable? So let me quote for you a couple of issues. At about the same time that preprint got uploaded, the other preprint that is much in discussion of how BCG vaccination and universal BCG vaccination policies of long standing are correlated with a relatively slower, lower, poorer spread of COVID-19, it was also uploaded as a preprint from the New York Institute of Technology. The two groups don't seem to have corrected for each other's parameters.
Right.
So it's a little unclear what to make of these patterns, especially because these are the kinds of pattern searches that are deeply meaningful at the end of an epidemic when you have all the data. When day to day your data patterns are shifting, to make these conclusions is really speculative to the point of coffee table conversation. Right. That said, let me point to two other issues. One is, there is a great deal of conversation about how BCG protects us.
Right.
And that is connected, and I'm bringing this up particularly because that is connected to a claim that is very commonly made in India, especially about Indian traditional systems of medicine, right, which strengthen your immune system. So let me say something about the biology of the immune system. The immune system sits quietly in your body, in all our bodies, until it is needed. It is triggered by an entering microbe into responding. So when we say we should have a strong immune system, what we generally seem to be implying is that we should have a pre-activated immune system. A pre-activated immune system is a problem. It's a problem because we are wasting energy and resources on having it activated when we don't all the time need it activated. And it's a problem because when the immune system is activated, sure, it does bad things to infecting microbes, but it also does bad things to tissues of the body. Right. We all know this with boils and abscesses and this, that, and the other. So having a pre-activated immune system is not an unalloyed good. So anybody who claims that you are going to get a pre-activated immune system as a result of their medication, it's at least worth thinking about the possibility that they're selling you snake oil.
Right.
The second and an even broader problem, and the last point that I will make, is that much of this evidence that we are claiming exists out there is evidence that is in preprints, in anecdotal fashion.
Right.
And we need to be careful that papers which the scientific community has not had the opportunity to discuss broadly, to critique widely, and to do follow-up work on, right, and therefore establish as reasonably acceptable or not, remain speculative, even as far as the scientific community is concerned.
Right.
For the community at large to take as given truth propositions and speculations that the scientific community is still thinking about as provisional and speculative,
right,
would be an inversion that we really should not enter.
Right. Thank you so much, Dr. Rath, for talking to us.
Thank you.
That's all we have time for today. Keep watching NewsClick.